Immuno-Oncology. I warmly welcome you all to today's webinar on Neoadjuvant Immunotherapy, Head and Neck Cancers. To begin with our welcome address, I would like to invite Dr. Rakesh Shalali, sir. He is the President of IOSI and Director in the Department of Radiation Oncology at Apollo Proton Cancer Center, Chennai. Over to you, sir.
Thank you. On behalf of the Executive Committee and everyone here at the Indian Immuno-Oncology Society of India, it gives me great pleasure to welcome you all for today's webinar. As you know, IOSI has been going on from strength to strength. We started about a few years ago, and now it is the premier platform in the country and one of the premier platforms in the world, where all the scientists and clinicians come together for a very exciting field of immuno-oncology. Last year, we started the series of webinar, and we had an extremely successful basic science webinar earlier this year, hosted by our colleague, Professor Girdhari Lal from NCCS Pune. And the next webinar was slightly more towards the clinical side, and this was being organized by Dr. Sujit Kumar Molapale, who is an executive committee member on the IOSI and also the organizing secretary for IOSOCI in 2026. And I must compliment the Federation of Head and Neck Oncologists led by Dr. De Cruz and his colleagues, and Dr. Jyoti Bajpai in particular to coordinate with them. They are our co-sponsors or co-hosts of this webinar. I will take a minute to invite you all for the very exciting 7th Annual Congress of the Immuno-Oncology Society of India, which is going to be held from 22nd to 25th January in Chennai. It will be in a beautiful venue, Taj Fisherman's Cove in Chennai, and 22nd will be devoted on 2 workshops, one on clinical trial methodology in immuno-oncology, which was my dream for the last 1 or 2 years, but finally we are doing it. And parallelly, Professor Girdhari Lal with Dr. Vani from Indian Institute of Technology, Madras, are organizing also a workshop. All the details are on their website and already some information has gone. Next slide, please. The theme of the meeting is immuno-oncology in multidisciplinary care, cancer care, and how do we generate paradigms given the impact of immuno-oncology in cancer. And we are very fortunate to have a galaxy of international experts joining us, including Professor Odunsi, who is a formidable name at the AACR in Chicago. And he will be our orator of the IOSI meeting. Professor Vijay Kuchuru, who is also a very, very eminent name in Dana-Farber, Harvard in Boston, who is also going to give the oration. And also other experts like Professor Shaji Kumar, Michael Prados, Gladwell Clare, and also Dr. Herbert Lung from Hong Kong. We are also pleased to tell you that we have already crossed roughly more than 300 registrations, which includes more than 150 paid registrations and about 150 faculty. It may likely cost 350 to 400. We are very excited. Next week or next 2 weeks, you will get the program and the scientific invites. And these are the QR codes for lifetime membership. They are very attractive prices for abstract submission. Please convey this message to your students and trainees and everyone in your labs and the clinic, and also the QR code for registration. We are offering 25 travel grants for outstanding abstracts on first come first serve basis to people less than 40 years. So with this background of the next IOSICon, now I invite my colleague, Dr. Sujit Kumar, who is the program director of today's webinar, to formally introduce the webinar and also tell us about the content agenda as well as the speakers. Thank you very much. Dr. Sujit, please.
Thank you, sir. Welcome all of you to the webinar today. As we were discussing, it's very important to know about immunotherapy in this current era. And that's why next year in the IOSI, we have taken up the topic of multidisciplinary care, the role of immunotherapy. So we'll be discussing different topics based on the neoadjuvant and adjuvant aspects of how we'll be using immunotherapy in multidisciplinary care. So today we thought we should have a start ahead to this topic by going to neoadjuvant immunotherapy in head and neck cancer. Head and neck cancer is like India's primary domain in oncology. So we have eminent professors in oncology, Dr. Kumar Prabhas sir, Dr. Atul Sharma sir, and Dr. Vijay Patil sir. They are going to speak about and discuss an important topic of neoadjuvant immunotherapy, which is changing the way we are treating head and neck cancer. Neoadjuvant chemotherapy has a role to play in head and neck cancer, especially if it's a borderline resectable. Many of the data coming from India. After the advent of immunotherapy trials in neoadjuvant, we are seeing that many patients are going to benefit with neoadjuvant immunotherapy. So, Dr. Kumar Prabhas sir hasn't joined yet. Yes, sir has joined. I invite Chairperson Professor Kumar Prabhas sir to say a few words and invite the first speaker. Over to you, sir.
Hi, good evening. Good evening, everyone. And today we have a significant topic for discussion today, and very relevant and very important. And I invite Dr. Atul Sharma, sir, for his lecture today. Sir, and everyone knows Dr. Atul Sharma, sir. He doesn't need any introduction. So, sir, floor is all yours.
All right, so I already shared my screen, so let me. Anshika, it is there?
No, sir, I'm not able to see the screen.
Okay, so before we did it go, just a minute. Is it now?
Yes, sir. You can just put it on slideshow
Slide.
mode. Yeah.
Okay. All right, good evening, everyone, all friends and dear colleagues. So thank you, IOSI, its executive committee, office bearers, and the most important thanks to Sujit for giving this opportunity and organizing webinars for the sake of the knowledge for ourselves as well as younger colleagues. So rightly chosen topic, I'm going to discuss briefly about updates on neoadjuvant immunotherapy. We have recently had data presented in important meetings, and I would like to beforehand acknowledge that few of these slides have been borrowed from us purely for the educational purpose. So briefly touching about why do we need immuno-oncology or immunotherapy in head and neck cancer? Despite whatever we do, despite so much of this thing research by Kumar Prabhas and colleagues and other people, we are still struggling that high cure recurrence rates and mortality despite whatever we do. And many of these tumors initially, particularly in our country, when they present in unresectable status, usually we do not have second line or much more option once patient fails the platinum based chemotherapy. This thing. Traditionally, immuno-oncology or head and neck cancer are considered hot tumors because of the frequent association with the viral etiologies, just like EBV and HPV. And when usually it has been found that whenever they found that possible mechanism for the disease progress, maybe that these tumors become immune evasive because maybe that because of upregulation of PD1, PDL1 axis or T cell exhaustion. Most of us believe, and there are data to suggest that there exists the inflammatory microenvironment, cytokine stills, and the myeloid suppressor cells, which provide some home to the immunotherapy targets. And the biology of head and neck cancer makes them thus attractive for immunotherapy approaches. We are very well versed with many of the solid tumors where the immuno-oncology are making some changes, be it in the neoadjuvant setting, adjuvant setting, and palliative setting. With regard to the systemic treatment in head and neck squamous cell carcinoma, when we started our career in 90s or even before that, the only option probably, only use of systemic treatment most of the time in the palliative setting, methotrexate, bleomycin, cisplatin, 5-FU, and so on. Later on, there was evidence started developing that the chemotherapy may be an important constituent of the armamentarium for the treatment of head and neck squamous cell carcinoma, started using chemoradiation. But still, after so much of the advances, we do not have a protocol which has concretely proven that the neoadjuvant chemotherapy will be useful in this situation. So obviously, there is a lot of scope for the improvement, and the immunotherapy, as I said, is major player in various other cancers. So trials have been going for the head and neck cancer also. So evidence so far we have been got for in the last few years is that probably we have evidence that the pembrolizumab works in platinum refractory and first line setting in recurrent or unresectable tumor based on the data from the keynote 012040 and the most importantly 048. And the nivolumab did show improvement in overall survival compared to the standard therapy in relapsed refractory squamous cell carcinoma, checkmate 141. The beauty of some of these responses is that some or minor of these responses may be durable response. That means suggesting some of these patients may be long-term survivors. And of course, we have evidence that the patient who possess PDL1 positive tumors or those who have the HPV positive tumors will have better prognosis than the rest of the population. This is the published literature so far with regard to in the unresectable or metastatic setting. We have evidence from the keynote 012, which probably laid the foundation for 048 trial, which confirmed that the pembrolizumab plus chemotherapy may be better than the extreme trial, and survival benefit was documented mainly in the patient who possess a CPS score of 1 or more or 20. In the CPS score of 20 or more, maybe the single agent may also be effective. And checkmate 141 is showed nivolumab in the refractory setting. So so with that background, we had a lot of studies are ongoing, and now we know that the future is precision immunotherapy, integrating with multimodality management. Most of the solid tumors nowadays have been witnessing the trials consisting of the immunotherapy plus chemotherapy, immunotherapy plus radiation, immunotherapy plus targeted therapy, along with the surgical care. So there are various biomarkers which have been studied and found to be useful in this setting. So PDL1 combined proportional score, then TMB, HPV status, gene expression signature, which may suggest that these patients are likely to derive better benefit than the rest of the population. Various trials are ongoing, but the challenge of this immunotherapy in the many solid tumors, or rather I would say all solid tumors, is the immune-related adverse events, their management, patient selection, and very, very importantly, in our setting will be the cost. So these are the few trials which have been tried in the squamous cell carcinoma head and neck in the neoadjuvant or adjuvant setting so far, beginning publication in 2020. Durvalumab plus tremelimab, which one is the PDL1 inhibitor and second the CTLA4. The patients were given 2 cycles before surgery, either the Durva alone or Durva plus tremelimab. The only thing is that probably there were no significant improvement and that grade 3 toxicities were more than 14%. So in one way, this is the probably these are the most of the trials listed here, except 1 or 2 are the negative trials. We have a checkmate 358 trial where they tried nivolumab and on day 1 and 15 prior to the surgery. It was feasible, did not delay the surgical procedures. Modest pathological regression was noted, but from the beyond that, it was just author concluded it was well tolerated without any significant outcome in the improvement. We have a use of the nivolumab ipilimumab trial also, but this also did not improve the outcome, except there was a 35% major pathological response in the arm where the combination treatment was given. That we also have evidence for the we also have the publication of evolumab, but again here probably except numerically better perform progression free survival, no significant improvement was noted. Thereafter, we have a trial published in 2022, which laid the foundation for the current trial, which I'm going to discuss in detail. Multicentric phase 2 trial, pembrolizumab, 1 or 2 doses prior to the surgery, then the surgery, adjuvant pembro plus standard of the care. This trial suggested that because of this approach, there were no surgical delays in the surgical procedures. Pathological responses were noted and that predicted the disease-free survival, and there was improvement in the 1 year disease-free survival in the intermediate risk population. And now we have the current trial, which I'm going to discuss in a little detail. So these are the trials which I was talking about. Nivolumab Checkmate 358, Nivolumab plus EP, M-Season, then Durva plus Tremi, CIO, and this current trial. This was the presentation late-breaking abstract and the publication recently, a couple of 2-3 months ago, ESCO, neoadjuvant and adjuvant pembrolizumab in locally advanced head and neck cancer. Good thing is that this was led by an Indian scientist. So Keynote 689 trial, this trial recruited the patient who had resectable locally advanced head and neck squamous cell carcinoma. Patient may have all head and neck subsite except nasopharynx. If this was the P16 negative, then these were the patient oropharyngeal stage 3 or 4A, or P16 positive oropharyngeal cancer, T4N0 or N12, that means the stage 2. This trial required that the patient should have a performance status 0 or 1, which sometimes we may not find in our setting, and trial probably required the tumor tissue for PDL1 testing. The patients were stratified based on there was stratification by used based on the primary tumor site, oropharynx, orocavity versus larynx, hypopharynx, tumor stage, and PDL1. For the stratification, somehow or other they used, instead of CPS, they used the TPS. More than 700 patients or subjects were randomized between the two arms. One was the standard arm, which probably surgery, followed by radiation plus minus chemotherapy based on the risk factors. And the experimental arm was the pembrolizumab 200 milligram every 3 weeks, 2 cycles, 3 to 4 weeks later on the surgery, followed by 3 more cycles of pembrolizumab during radiation. The patient who had the high-risk features, which usually we take into extranodal extension or positive margin, were also given chemotherapy. And thereafter, the maintenance pembrolizumab 3 weekly for over a period for total of 12 doses. So these are the baseline characteristics. These are the baseline characteristics, basically well balanced. The good thing about this trial is that they did not have any upper age limit. So you'll see number of these patients were in the age group of 80s, late 70s, 80s, and this thing. As expected, most of these patient population was the males. ECOG, as I said, 0-1, representation from the North America, European, but rest of the world as well. About 40-45% different ethnicity were enrolled. Tumor size P16 positivity was very low. This is one thing which we need to discuss in the discussion section. Most of these patients were the P16 negative. PDL1 status was more or less either the 1 or more than 1. Most of these patients these population was PDL1 positive and current or former smokers and this thing. When I reviewed this paper and came to read it in detail, close to 90% of the patient in pembrolizumab group and little over close to the similar population in the control group underwent surgery. That means only 10 to 12% of these patients probably could not undergo surgery, either disease progression or other reason. The other important point is that about quarter of these patients would not initiate post-operative treatment. That means only 3/4 of the patient went up to for the post-operative or adjuvant treatment. So this was a sequential trial design. That means initially they thought based on that statistical design in case they find that and I probably didn't discuss, but the event-free survival was their primary endpoint. Scores of secondary endpoints were the oral survival, progress, major pathological responses, toxicity, and so on. If you see this particular slide, you will find that the patient, so this sequential sequential analysis design means that initially they thought that they will see in the patient population who have the CPS score of 10 or more. In case it shows a positive attitude, then they will review, then they will analyze CPS equal or more than one population. And if that also is positive, then they will include the all population. They will do the analysis for the all population. Having said that, most of these patients were CPS 1 or more, so hardly very few patients were, I would say, that the CPS negative. The second important aspect which I'll be showing here is that you see the curve started very wide, separating at the end of 1 year. And there is a delta of about 10, 14, 13, 14%. And if I scroll it down, you'll find at the end of the 2 years also almost similar benefit, over 10% of the benefit. And if you see for the 3 years EFS, EFS rate was about 60%, 45%. That means that benefit about 10 to 15%. This was in the CPS score for the population who had the CPS equal or more than 10. I probably draw your attention now to the patient population who had the CPS score of 1 or more. Again, almost similar outcome. They start 75%, 61%. At 1 year, about 13, 14% difference. At the end of 2 years, about 10, 11%, and 13, 14 difference again here. So hazard ratio for the patient population of our CPS 10 or more was 0.66, highly significant p-value, well within the distinct confidence, well within the under 1. The median median EFS in this particular group was about 60 months, that is about 5 years, compared to little over 2 years in the standard of the care. When we come to CPS score of 1 or more, it almost similar benefits, close to 5 years versus little over 2 years. When I now, I would like to draw your attention to the EFS by all participant irrespective of the PDL1 status or CPS 1 or more. Again, this almost similar benefit. This is because most of these patients were the PDL1 positive tumor, magnitude of benefit almost equal. When we come to the one of the secondary endpoints for the major pathological response, there was significant difference in all the 3 groups, CPS more than or equal or more than 10, more equal or more than 1, and all participant. Pathological responses were not very great, unlike many other solid cancer. The distant metastatic free survival, which was one of the secondary endpoint, there was significant improvement in the patient who received the immuno-oncology before in the neoadjuvant and the adjuvant setting. One of the secondary endpoint was time to locoregional failure. There was no significant difference in this, because after the disease progression, patients were allowed alternate treatment, which most of the time included the immunotherapy. No new safety hazards as expected in the patient who are receiving immunotherapy or chemotherapy. There was no matter. Most of these patients had some or other adverse event, about 80% or more. Discontinuation of the trial treatment due to adverse event was seen in about 17% of the patient in the pembro arm compared to 12%. And beyond that, probably most of the time these were as expected. The other thing I would like to draw your attention, the patient's probably adverse event leading to death was 4 in the pembro plus standard of the care arm compared to only 1 death in the standard of the care arm. To summarize neoadjuvant and adjuvant, these are the author's conclusion. I'll come to mine later on. Also, neoadjuvant and adjuvant pembro added to standard of care significantly improve EFS for participants with resectable locally advanced head and neck cancer, irrespective of PD-L1 CPS, was associated with the higher distant metastatic free survival. Rate of local regional failure were similar between the arm, no new safety signal. Neoadjuvant pembro surgery and adjuvant pembro concurrent with and after post-op chemoradiation or radiation represented new standard of care for patients with resectable locally advanced head and neck squamous cell carcinoma. Another important aspect, learning point is that age is just a number. Basically, until now, most of us have been not using systemic treatment beyond the age of 70. So this is something new. So my take on this particular study and answered questions, relative contribution of the neoadjuvant versus concomitant versus adjuvant pembrolizumab. Remember, these patients received uh, 2 cycles prior to the surgery, then in the adjuvant setting also, and thereafter in maintenance also. Indirectly, study arm had 3 times longer treatment duration, close to 9 months compared to 2.5 to 3 months in this standard of care. Very few patients had the CPS negative tumor or HPV positive tumor. So whether we can draw similar conclusions of oropharyngeal tumors which had HPV positivity, difficult to say. I would say that a finger crossed. Stratification was based on TPS, and about 25% of these patients could not start post-op therapy. And another important point is that whether we are willing to take EFS as an endpoint, because OS data are not mature and not definitive, but so far, whatever is available does not suggest that there is improvement in the overall survival. They wanted it to be less than 0.02, 0.025, but it's as of now is this thing. So whether another important point which we need to remember is that this, because of the treatment of number one, we have to order PD-L1 in the initial biopsy for most of the patient. That will delay some biopsy result. Number two, these patients will receive there will be delay in the surgery for about 6 weeks, and majority of the patient in the private sector may or may not like that. Now we also have the important we have data neo post-op which suggests 6 months of nivolumab also gives similar kind of the cross. If you really want me to do the cross trial comparison, similar benefit. So whether we need to give immunotherapy for 6 months or 1 year, that is I think need to be really discussed, and I'm sure few of these points Dr. Vijay Patil will be discussing. Still, bottom line, I would say perioperative pembro meaningfully improves EFS with modest absolute 3, again 11 to 14%. And most important drawback, or probably most important thing which probably may not allow most of our patients to go for this particular approach may be the cost, or rather will be the cost. So whether I consider this as a practice changing, yes. Whether I'll consider, maybe yes, for the eligible patient, not for everyone, with the caveat that we don't have the OS data, and OS data may be altogether different. With that, I would like to conclude, and thank you very much for the patient hearing. Any questions, comments are most welcome.
Thank
we
you
will
for this.
address all the questions in the end. So I really request you to please be there. In the last 20 minutes, we'll be having a brainstorming session considering all the questions.
Absolutely. Absolutely.
Thank you, sir, for that excellent presentation, giving all the details of the trial and even putting your critical review about the trial. Now, I invite Professor Vijay Patil for real-world challenges in using neoadjuvant IO in head and neck cancer. Over to you, sir.
Thank you, Sujit. I hope I'm audible.
Yes, sir. Yes.
Can you just share my screen? Yeah. So next slide, please. Next slide. So resectable head and neck cancers, and let's focus first on resectable head and neck cancers because that is the situation where we would consider giving neoadjuvant immunotherapy at present. The question is, in head and neck cancers, resectable is considered a curative uh, option, resection. Now, are we satisfied with the option of the outcomes? What is the 5-year PFS or EFS for this patient? What is the 10-year PFS or EFS for him? And frankly, we have failed in improving the outcomes because neoadjuvant chemotherapy over the standard treatment option of surgery followed by appropriate adjuvant or CTIT dose escalation or hyperfractionation or addition of additional agents or addition of adjuvant immunotherapy or concurrent immunotherapy have not actually led to an improvement in outcomes. Next slide. So let's look at what are the outcomes of resected head and neck cancers. And this slide, though busy, is a very interesting slide and it is from RTOG 9501 10-year results. These are operated patients and post-surgery, they underwent RT or CTRT. And if you look at these outcomes, you look at the overall survival at 10 years are in the range of around 25 to 30%, depending upon whether they have any risk factors or they don't have risk factors. What does that tell us is when you're operating a 50-year-old person of head and neck cancers, at the end of 10 years, the probability that that patient will be alive is only 20 to 30%, which means 10 out of 10, only 2 to 3 patients which you operate are going to be alive at the end of 10 years. And this is in spite of doing many times large surgeries with flaps, with cosmetic changes, with radiation, which gives you xerostomia, dysgeusia, with chemotherapy, which gives you quite a bit of complications. Now, the thing is, how can we improve on these outcomes? Can we have the next slide, please? Now, I'm not going to discuss these results. These results were well discussed by Atul sir. What I'm going to point out is the table which you see in this results. If you look at the events, interestingly, neoadjuvant immunotherapy did improve outcomes. It improved the median event-free survival from 26 months to 59.7 months, nearly doubling, more than doubling. And if you look at absolute numbers, it's an improvement of around 14 to 15%, which is seen, which is considered relevantly significant in head and neck cancer. But this improvement largely happened because of improvement in decrease in distant metastasis. So if you see the difference in number is that the difference of the distant PD, where the events have decreased from a 16.9% in standard of care arm to largely 6.4% in the Pembro. I mean, we'll come to this in a little while. Can you move to the next slide? And whether we look at it with respect to CPS more than one population, we see similar results and similar marginal benefit of around 13 to 14%. And can we move to the next slide? And if you look at even patients who are all patients, this is largely influenced by, as was shown by Atul sir, most of the patients in this study were CPS more than 1. So you won't see much difference between this curve and the curve with patients with more than CPS 1. Again, showing that there is a reasonable amount of benefit which is there with this approach. Can we move to the next slide? Next slide, please. So the question is, why can't we adopt this? Is the EFS benefit not something which we want to give our patients? So frankly, in head and neck cancers, OS benefit is difficult to achieve. We actually, with cisplatin also, we required McKinsey analysis to come into place with large number of patients to show that an OS benefit is there. An EFS benefit is a reasonable amount of benefit which you would take. But to adopt this, we need to answer 3 questions. What about the cost of the treatment? What are the survival benefits? And what is related to the PD which the patients would have if they are on treatment? So let's go to the next slide, please. Now, what I'm trying to show here is that nearly 12% of the patients in both arms did not undergo surgery. Now, let's answer this first question. How many of us are willing to put resectable head and neck cancers give neoadjuvant therapy, and see that 12% of the patients do not undergo surgery. Now, in this trial, it was seen equal in both arms, where we see that patients have not undergone even surgery in the surgical arm. Can we move to the next slide? And if we come to an important thing, another few percentage of patients do not undergo radiation, that is adjuvant therapy after this, so which makes it around 1/4 of the patients not undergoing the adequate amount of therapy in this trial. Can we move to the next slide? So let's see what have other trials reported. This is a classical trial and probably the only trial which compared surgery to CTRT. And this was reported by Dr. Iyer from Singapore, and these are the 10-year result update. What I wanted you to focus is there is an arm of surgery plus adjuvant RT, which is in the table on your right side. And you could see that out of 60 patients, only 50 underwent surgery. And if you look at multiple data sets also, you would always see that for some reasons, 8 to 10% of the patients do not undergo surgery. Now, even if you look in this trial itself, if you see another 7 patients do not receive adjuvant RT. So it's like 17 out of 16 patients, 60 patients in this trial, which again roughly would be around 1/4 to 1/3, did not undergo adequate adjuvant workup. Now, for many times, we always think that every resectable patient should undergo surgery. But if you do a retrospective analysis, and this is an unpublished analysis from a major institute in India, and you could see if 100 patients are resectable walk in your clinic, in most of our institutes, not more than 70 or 80% would undergo surgery. I'm not talking about private practice, which may be slightly different, but in most of the academic institute, you would see that 15 to 20% of the patients, even though resectable, may not undergo surgery. So with that, we could safely say that this trial, though 12% did not undergo surgery, 25% did not undergo adequate adjuvant, this seems to be what is actually happening in even real world. So that should not stop us from adopting this approach. Let's move to the next slide. Now there can be a question, why not use neo post-op, where the patient undergoes surgery, and this trial from GOTEC also showed a significant outcome benefit. Can we move to the next slide? Now both the trials, GOTEC and Keynote 689, though has done a testing for oval, but a formal testing has not been done because an adequate number of events has not been done. And in both of the studies, we have a DFS benefit with neo post-op and a EFS benefit with Keynote 689. And more or less, the definitions of DFS and EFS are in line to each other. But what we see is the control in neo post-op is largely because of roco-regional benefit, and the control in Keynote 689 is largely because of distant metastatic benefit. Now, this brings to an important question, which Atul Sir also raised, whether it's the neoadjuvant component, it was the concurrent component, or whether the adjuvant component. What it seems from, at least from the neo post-op data, that your adjuvant component is actually helping at the loco-regional level. Whether neoadjuvant component helps at distant metastasis will actually require a head-to-head comparison of these two approaches. But it seems that at present, it might be wise, unless we get more data, to, if you're going to follow Keynote 689 regimen, to follow the way it was given in the trial, because we don't know what actually contributed to the distant metastatic benefit. Can we move to the next slide? Now the question comes is, how are we going to adapt this data in routine practice? And let's look at this ASCO discussion slide for it. And this was a hypothetical treatment algorithm which was discussed. And it said that today, if there is no tumor board, the patient would undergo direct surgery. But if there is a tumor board, there is a likelihood that the patient may still undergo surgery, or the patient may undergo neoadjuvant pembrolizumab. Now, let's focus on neoadjuvant pembrolizumab. If you give neoadjuvant pembrolizumab and do surgery, there are two things. If it is a high risk, you will give chemo, radiation, and pembro. If it's a low risk, you won't give only RT. You will go RT plus pembrolizumab. Now, one thing I need to point out here is Keynote 689, though the design was for neoadjuvant pembrolizumab followed by standard of care versus standard of care, the indications for cisplatin were dependent on post-operative HPR and modified post-operative HPR. So 10% less patients in the pembro arm received cisplatin. So this comparison is not only a pembro addition to standard of care, it's also a pembro addition to standard of care minus 10% less cisplatin given in that experimental arm. If you look at the other arm, if you go the neo-post-op way, you can do surgery, and low risk you might do observation. In intermediate risk, you might do radiation. There is one RTOG study because of which this cetuximab has been written in the ASCO discussion study. If it is high risk, you might do chemo RT plus nivolumab. Let's put this into practice by using a patient, and let's discuss how we would look at it. Can we have the next slide? Now, can we move to the next slide? Yeah. Let's say there's a 53-year-old man. He's a CA oral tongue, T3N0M0, stage 3, and he's a good surgical candidate. Now, let's say that if we treat him in neoadjuvant pembrolizumab, his T3N0, he would actually turn out to be low risk only, and you still would give RT pembro to this patient. But if you operate this patient upfront, he might still turn out to be T3N0, and you may actually not require anything in this patient because there is very limited data that T3N0 benefits with radiation also. So he may actually turn out to be with radiation. And so for this patient, peculiarly using a neoadjuvant strategy may not be the best strategy because you might end up over-treating this patient. Can we move to the next slide, please? Next slide, please. Let's look at another patient. Now, this is a 70-year-old man. Again, a right oral tongue, 2 centimeters, T3N0, but dirty looking disease and which is near to the mandible. Now for this patient also, because the T3N0, you might overtreat if you give neoadjuvant pembrolizumab. A surgery upfront approach would be a better approach, and if there is any high risk factor, you can always add immunotherapy in the background like neo-post-op. Can we move to the next slide? Next slide, please. Now let's look at these scenarios. A 42-year-old male who has CA buccal mucosa, CT4C4A, CN2, larynx, CT4A, CN1. Let's look at the first patient, CA buccal mucosa, CT4A, CN2. So in this patient, he is N2 patient. He is a high-risk patient. In this patient, remember the surgery done were according to modifications which happened after the immunotherapy. We would probably want to give for the buccal mucosa patient neoadjuvant pembrolizumab, and there might be a 10% of these patients who might be saved of cisplatin. CA larynx again, CT4A, CN1. This again is a patient you might want to use neoadjuvant pembrolizumab, and then this patient might again benefit may not require cisplatin at all. Hypopharynx, CT3N3. This is a tumor in hypopharyngeal cancers which have a high rate of distant metastasis. So this would be one situation which I would be more than willing, because it's T3N3 of hypopharynx and T3N1 of hypopharynx, to give neoadjuvant immunotherapy, because I want that distant metastasis benefit to come to these patients. Now, what has not got discussed in the studies is how would be the role of for organ preservation, like mandibular preservation or for laryngeal preservation, because all these patients underwent, remember, surgery. But that would be an interesting concept with more data coming in this field. Can we move to the next slide? But one of the concern was when you give immunotherapy, all patients don't respond. A few patients have progressive disease. So what could be an answer for that? The answer for that probably would come in some few years, because phase 2 data have already started to coming, is neoadjuvant chemo plus immunotherapy. And let me address you to this small study of camrelizumab alone versus camrelizumab plus TPF. And if you could look at the waterfall plots, you could see that a huge amount of patients actually had near pathological response. Complete pathological response clinically was seen in many patients, and major pathological responses were seen to the tune of around 76.4%. And can we move to the next slide? And those patients who had good pathological response for 36 months nearly had 100% event-free survival in this study. So the food for thought here that we are talking about neoadjuvant immunotherapy. In few years from now, we actually will be talking about neoadjuvant chemoimmunotherapy with this kind of pathological responses seen, which would dramatically change the outcomes of head and neck cancers. Can you move to the next slide, please? Now, one of the problem in India, next slide, please. Hello, next slide, please. Yeah. One of the problems in India is border and resectable cancer, oral cavity cancers. And this is a data from our own group of over 3,000 plus patients where we have reasonably established the role of neoadjuvant chemotherapy. Now, the outcomes still are not great. You see 5-year overall survival and 10-year overall survival in these patients. Those who undergo surgery is only 20%. Now, this is a dire needed group. And I think adoption of neoadjuvant chemotherapy plus immunotherapy in this group might lead to us having more benefits in this patient because these are the patients who are at a higher risk of local failures and also at a higher risk of distant metastasis. Can we move to the next slide? And let's come to an important question, which Atul sir put. What about the cost? Now, there is this data. This data comes from CMC Vellore of using low-dose nivolumab with induction chemotherapy. There is already a randomized trial going on across the country, which has already recruited 180 plus patients, and we might be seeing the results in 2027 or 28, depending on the events where we are already exploring low-dose immunotherapy with metronomic chemotherapy as a neoadjuvant therapy. But this data from CMC Vellore, though in the retrospective setting, is already out, which is showing quite interesting results where many of the patients who are border and resectable could, with low-dose nivolumab and induction chemotherapy, could become resectable. And interesting, promising 1-year OS of 83% in this group of patients. And maybe if cost is an issue, this might be the way to go. Now, but next slide, please. This is my last slide. Before we leave, understand that overall survival was tested in Keynote 689. The p-value which was required was a prerequisite of 0.02, which Atul sir has already alluded. We got a p-value of 0.04 with nearly a 9% survival benefit at the end of 3 years. Now understand this was an informal testing of overall survival which was done because required number of events for OS have not yet occurred. The way the curves are separating, normally in head and neck cancers, once the curves separate, they, with more data, they at least don't meet for the initial part where the separations are there. They eventually will meet after a few years. There is a good reasonable probability that this trial in 2 years or 3 years down the line would show overall survival benefit. But I guess by that time, world would have moved to neoadjuvant chemotherapy with immunotherapy. So can we move to the next slide? And this is my concluding slide. So for today, if you are an operable locally advanced head and neck squamous cell carcinoma, with this data, immunotherapy is here to stay. Now, whether you want to use immunotherapy in the neoadjuvant setting versus in the adjuvant setting in an affordable patient needs to be a multi-tumor board discussion. It needs to take into consideration the volume of the disease of the patient. It needs to take into consideration the CPS score of the patient. It needs to take into consideration also what is the risk of distant metastasis this patient has and how good a candidate this patient is. Now, but the development of therapies in neoadjuvant in border and resectable head and neck cancers have taken the path of most of the time with retrospective studies. And I really feel that immunotherapy, in addition to chemotherapy, would be, I actually would be discussing with my patients as an option for border and resectable head and neck cancers because of the amazing results which were seen by the carmalizumab with EPF study. With that, I'll stop here. I think I've exceeded my time by 5 minutes. So I'm sorry for that. And I thank Jalali sir, Jyoti ma'am, and Sujit for this opportunity. I'll be happy to take if any questions on them. Thank you.
So thank you very much. I think Dr. Sharma and Vijay, though you both, did a great
Thank you, Vijay.
and precision oncologists. Everybody come on board and let's discuss very genuinely that how these two trials, as Dr. Sharma also alluded, that these are truly practice changing trial. But whether on the Monday morning we are changing practice or we have already changed or we are in the process, that all we need to discuss, and what are the caveats, what are the final points we need to discuss here. So, the floor is really open and I want speakers also. So Vijay, I want your face still on the camera mode. And Dr. Kumar was here, and I believe Dr. De Cruz must have landed by now. So his opinion will also be of immense importance. And I believe our FHNO colleagues, although there is a national thyroid meeting which is going on, in spite of that, they are in and out. So whosoever can join, please switch on your camera so I can identify and ask the questions. Otherwise, I'm throwing some general questions, and everybody's opinion is very, very valuable. So see, these two strategies now, they are new kids on the block, that we have a new adjuvant, Pambro, so peri-op, truly peri-op. And it is very fascinating. It's first over peri-op approval in head and neck. So this is very fascinating. And it's gratifying that, it is showing a good survival trend. And EFS, I believe, especially because it's a new adjuvant strategy, it looks like a decent endpoint. And as we are seeing that the trend is looking that, it may reach to overall survival, but so far we are not there. And this was, intermediate to high risk population versus, as was mentioned by both the speakers, that post-op Nivo is also on the board, and that is purely high risk. And we have seen that there are two strategies a little bit different. That in one, post-op Nivo, it is mainly the local regional control rates which were substantially increased, and that leads to the improvement, while in the peri-op Pambro, it is essentially the distant metastasis-free survival. So which one we will consider and which scenario? Few cases Vijay has very interestingly shown, and that is also in the further real world. So I would like to ask first question from any sir. Dr. Jalali is there, sir. Please, your comment. Your hand is
No,
raised.
I really enjoyed. Thank you very much for the fascinating discussion. 2 points were also very interesting for me, although I'm not so much into head and neck these days. One was that 63% of the patients were oral cavity, which we think is an Indian subcontinent disease, and yet in this trial, a substantial number was oral cavity, not the oropharynx, which generally we accustomed to. I have a very fundamental, very naive, basic question that the neoadjuvant pembro, it seems, did not improve the PCR rate and therefore no loco-regional advantage, but it seems there is a definite trend towards significant improvement and disease-free distant metastasis, which Vijay also and Dr. Atul showed, and yielding an EFS, although OS is not there. But generally speaking, what we have been told, when the disease burden is large, you don't give immunotherapy. You want to have a relatively small disease for it to work. Scientifically, how does it work when you have a large burden of locally advanced head and neck cancer? You give neoadjuvant, delay the primary treatment to some extent, which also was highlighted significantly. And yet you seem to not benefit too much the loco-regional, but have some impact on the distant metastasis.
So I think extremely important question. I would direct this first to Dr. Sharma and then to Vijay. And now I've seen Dr. De Cruz has also joined. So then I will ask Dr. De Cruz as well.
So first and foremost, let me say, yeah, Dr. Rakesh and others, probably I enjoyed the discussion by Vijay, and the only point I would like to see is that these are the stage 3 and 4A, and these were the most of the time, probably I believe, though I don't have this anything written in the supplementary also. These are not the kind of the patient usually we see in our routine clinic. So what I meant to say, they are not very really large volume disease and this thing. So that's one point that you were asking. If the disease volume is large, we usually don't give. We prefer to give cytotoxic treatment. And the trial design, and I personally agree to the what Dr. Vijay was saying in this thing. So unlikely, because there were not many responses seen. So the time duration, usually when talk about the immunotherapy in clinical practice, we say usually take about 6 to 8 weeks to get some kind of the response. That indirectly would mean that these patients should have been given three cycles or 4 cycles, 3 cycles at least to get about 6 weeks or so. That may be the reason that we didn't see much of the response in this thing. And I agree to the Vijay's discussion, what he was discussing. So unless we get a major pathological response, if you see hardly very few people get major pathological responses, and pathological CR was probably kind of the negligible. So these are the reasons that basically these are. Personally, I think that since these patients were resectable, they probably may be a selected group of the patient and this thing. Vijay would like to add something probably with regard to the distant metastatic free or
But I
local immunotherapy.
agree with you. These T4As are the T4As which you get on CT scans and MRI. These are not the T4As like we see clinically and say this is T4A. Clinically itself T4A. This would be like T2, T3. They did a scan and then they turned out to be T4A. The kind of T4As which we see, we know. So there is no doubt that the volume and the burden of the kind of disease which we see in clinic, these are not those patients which were taken in the trial. So if I see a large mass with the skin getting involved as a T4A and my surgeon is trying to tell me give only neoadjuvant pembrolizumab, I would be a bit skeptical of giving neoadjuvant pembrolizumab in this setting. I would always want to add chemotherapy with that, or I would ask him, you operate first and then I will I would take the lead. And that would be the reason why the local regional controls are pretty high in these patients. And the difference which was seen was in the terms of distance. I completely agree with that. These are not the kind of patients which, as Indians, we see in our clinic. And as you would also pointed out, the burden of the disease in head and neck cancers, which we see even in private practice, very few of our patients are actually PS0. Most of them are a PS1 or PS2. You hardly get a PS0 which is a T4A oral cavity.
And
Yes,
that too in an elderly population, the median age was quite
60.
And then to get such a small cancer, 60. I mean, this is important point in our setting. So when you say practice changing, this is a very important point to my mind, the volume of the disease, especially that we see in our practice. Jyoti, I think Dr. DeCruz has joined.
Yeah, so exactly. I want to ask Dr. DeCruz the same question, and very, very rightly pointed out by everyone that we have to be very selective. So this is practice changing, but for that select subgroup. So that we have to very carefully see, and our patient population, especially what we see day in and day out, is kind of more advanced and more more fastly growing. So in those patients, I think the idea of combining with chemotherapy is excellent. So, Dr. DeCruz, your comments, please, on both the studies, which patient you would be wanting to wait for 6 weeks and give it to me.
So, Jyoti, anyway, good evening. So, waiting for me. I hope Atul and Vijay, I heard some of Atul's comments at a meeting a fortnight ago, but a very, very important topic. While we say practice changing because it does show some improvement in event-free survival, and even the post-op Nevo did show benefit, I have a few comments. Now, I agree with what Atul, Vijay, everybody said. Now, you have to understand this in 2 points. One is that you're improving overall survival, event-free survival, and to put Rakesh's comment into perspective, the rationale of giving neoadjuvant, in my understanding, and I know I'm preaching to the choir here, is to prime the immune system, and then subsequently you would get a good response in terms of overall survival, distant metastasis, plus. It is not like Vijay said in our patients, which are borderline resectable, you'll miss the boat if you give single agent and you won't be able to operate them. If it's that kind of a case, it's a different approach. So I see immunotherapy coming finally into treatment in 2 ways. One is to improve outcomes, overall survival, event-free survival, that we can debate. And the second is to give us good response And then we do what is known as response adaptive surgery. That means shrink the tumor. And there was an oral presentation this time at ASCO, and they asked me to reply to that presentation. So that's a second approach. Now, in all our comments, we are mixing the two. So we have to see. But my take on both these papers is they're very heavily biased towards the investigational arm. The patients are heavily overtreated. There's no rationale of adding immuno along with radiotherapy, whether to give it for 6 cycles post-op, give it for 12 cycles post-op, omit it pre-op. Both the studies have just caused a lot of chaos in my mind on the right sequencing. So I think it does show immensely limited tractability in our country because of cost implication, but we'll keep it open because it's level 1 evidence. But I don't believe all level 1 should be just aped immediately. We need more data to come, which will then tell us how to use it, at least in my head and neck practice.
Dr. Sharma, please, your point to me.
Yeah, another important point I wanted to highlight for the younger colleagues is that probably this trial, even the supplementary, as of now, we do not have a data because they did stratify based on the stage 3 versus 4A, but the separate curves or the data, what was the magnitude of the benefit in the stage 3 versus stage 4 was not mentioned. I'm sure Vijay will agree to that.
Yeah, I agree with that. Yeah.
So Vijay, what is your take? If we want to really dissect out which strategy looks more feasible in our situation, especially we are seeing more high risk patients, and what is the take home for both these studies as far as you are concerned?
So for me, it is, see, if you have a resectable cancer, you discuss it today. And you need to discuss it as to do what is the bulk of the tissue, how many lymph nodes are positive, which is the site of the tumor. So if it's like for hypopharynx and large T4As, multiple nodes, I would be tempted to give immunotherapy, but I would be practically tempted to give immunotherapy with chemotherapy to this patient if this is a large bulk of them. If this is a patient which is like a radiologically becoming T4A, I would definitely discuss the option of immunotherapy today with the patient, telling that there's another option of not going upfront with surgery and then using a post-op, and I would lay both the options to the patient because as of now, Dr. Jyoti, 15% or 14% EFS benefit is something which you can't just keep out of your sight, and you need to tell both the options to the patients. Practically, I'll take one
No,
question.
I completely in sync.
Yeah.
I completely think there is a reasonably good option level 1 evidence.
Correct.
We need to discuss. We have to carefully see and choose. And there is an elephant in the room, whether we want to recognize it or not. It's kind of a situation, but we have to be very, very cognizant and judicious while deciding which patient is most suitable for which kind of approach. Now, Sujit and Dr. Girdhari, quick comments, please. And I want to hear from Dr. Kumar as well. I can't see, sir, he was there before. If
Yeah.
somebody can call him if he's new to
Sir
something.
had to leave here, called me, madam. He had to leave for he will join back. So
Sure.
two questions I wanted to ask regarding HPV testing, which was part of the study. So we don't routinely do HPV testing. So does it mean, and the number of patients who had HPV positive was less in this trial. So does it mean to rule out HPV is important before we decide for immuno? And second question to Dr. Vijay was, we have done DC versus DCF in TMH. So we know the toxicity is more with DCF. So if immuno is part of the care in the neoadjuvant, would you prefer still DCF or would be happy to go with DCF? I had a patient of borderline resectable, basically unresectable T4B oral cavity, which I planned with DC and nivolumab. And he had gone surgery and it became pathologic complete response. So I think the immuno worked because DC alone is unlikely to give a pathologic complete response in a patient who has a T4B N1 disease, CA oral cavity. So I wanted to know about this from Atul sir and Dr. Vijay.
So quick comment, Vijay. Dr. Atul.
So from my point of view, Sujit, practically, I'll tell you, if today I get a borderline resectable head and neck cancers, uh, I actually give the option of immunotherapy combination with chemotherapy. I don't combine it with 5FU because 4-drug regimen to me seems to be too much. So I normally combine it with taxane, platinum, and immunotherapy. I also actually give the option of metronomic with immunotherapy because even in the platinum refractory setting, metronomic with immunotherapy in the TMCI study gave a response rate of around 63 to 64%. That's quite a huge amount of response rate, which you normally don't even see with chemotherapy. So I actually use this two regimens for borderline resectable cancers.
Dr. Girdhari, your comment.
Yeah, so it's a fantastic talk. Actually, both the speaker did very well in presenting the talk. My question related with the mechanistic study, what Dr. Jalali raised the question, why actually in distal node you still don't see the progression of tumor? So one way probably the radiation therapy, just like what we know about abscopal effect, is that the immune response activation with the adjuvant or neoadjuvant is driving, or radiation therapy was given was driving? What is your comment in terms of mechanistic point of view? Why there was no actually distal metastasis in these patients?
So, Dr. Atul, you want to take this?
Yeah, say that. Can you repeat? So why there were no distant metastasis?
So the
So I
most
think
of
he
the
wants to
patients,
ask the why there is
right?
a distant metastatic survival benefit. I think he wants
Benefit,
to
yeah,
ask.
that's correct.
Yeah, like Vijay explained earlier, basically these patients population, they were, I think they all were the resectable tumor. And like Dr. Dikru said, the immunotherapy by and large are probably used as this thing sensitization or priming only. So these patients, since they did not have the locally, they underwent surgery after local early stage 4A, or most quarter of these patients were the 3. So tumor was resected out. So probably, in my opinion, escopal effect wasn't there because the tumor already has probably most of the time. These were the resect. These were not the metastatic disease or tumor in situ was not there. Tumor has been taken out. So escopal effect probably it wasn't there. But what these patients had the otherwise good performance status and a good outcome in the, like Vijay has shown the outcome what was expected out of these patients whenever there was some kind of the distance metastasis that lead to the treatment failure rather than the locoregional failure in the neoadjuvant arm.
Yeah, so I think immune priming
Right.
was extremely important, and as
I think
Dr.
Jyoti,
Sharma
there are some
mentioned.
question in the chat box, so question and answer also, if you can take
Okay.
this thing.
Okay, sure. So, any role
Thank you.
of radiotherapy in immunomodulatory effect in head and neck cancers in neoadjuvant setting, either alone or in combination? So, Dr. Jalali, you want to take this from radiation side?
Sorry,
Radiotherapy as an
the
immunomodulator in
people,
neoadjuvant setting.
yeah, people have tried it as a neoadjuvant. Vijay also showed a little bit of data. So it has not really led into it. The question would be, along with immune checkpoint inhibitors, can we use it? That is an interesting point. What is your feeling, Vijay?
Sir, if you look at the study which was done for pembrolizumab, which was CTRT versus CTRT with pembro followed by adjuvant pembro. Sir, it is reported as a negative study, and one of the reason why it got reported as a negative study because I would say that the investigators were over ambitious, and they had put that they would consider the study positive only if the p-value was 0.025 or below. The study ended with a EFS benefit of 0.041. So if we look at that strategy, it seems that there is some amount of benefit, but the amount of delta benefit which was required to say that the study was statistically positive, that was never achieved. So on that basis, I know that the head and neck group of Tata at present is planning a trial of low dose immunotherapy along with radiation and chemo. Taking this into consideration, there was a benefit which was seen. So there is a benefit. So the issue what is going to happen is a lot of our cancers are actually oral cavity and many of them are heavy tobacco related. With the kind of submucosal fibrosis which we have and the hypoxia which we have, we actually don't know how much amount of immunotherapy or anything which we give actually is going to reach the tumor bed. That's a challenge which will be answered only when we do a study in our setting. Because even if the keynote 689 had a large amount of oral cavity, all of them were not as heavy tobacco or jarda users like the one which we see in the OPDs.
But only thing, one other perspective would be that, these heavy tobacco exposed may be having more mutations. So perhaps we need more biomarker driven approach wherein tumor mutational burden, MSI, along with PDL1. Here also PDL1 was little, how to stratify. All comers were benefited, but less than one PDL1 was very few. So I think we need to have, kind of adopt a biomarker driven approach as well. And we are yet to find a perfect biomarker. Even the microbiomes and metabolomics, which are coming in a big manner, especially even in metastatic head and neck. I was reading other day that with the bacterial, bacterial form of stools, we can really see that this head and neck patient in metastatic setting would do better versus not. And similarly, the metabolomic approach within the tumor, indoleacetic acid was one of the component which was found that this can be associated. So there are plethora of data which is emerging. Perhaps in a later point we will be better stratify these patients and better able to choose which person for which approach. That would be probably like you very rightly pointed out, that our population, our solution, we perhaps need something more than immunotherapy. Neoadjuvant approach is good, but perhaps we need over and above something in the form of full chemo or metronomic fashion, something of that sort. But there is we need to really choose very carefully that what is the pace of the disease going, what is the site of the disease, whether there is a difference of waiting 6 weeks, make it like from hemiglossectomy to total glossectomy. Something of those things are also very, very important. So that's where I believe that multidisciplinary tumor board, taking everybody's opinion and discussing, has a big role. So I
Can I ask
think, yeah, please,
one more
please.
simple question? Vijay, the more metastasis is seen in, is it not seen more in larynx and hypopharynx than oral cavity generally? Number of distant metastasis.
Sir, if you look at with respect to distant metastasis, the highest is seen in hypopharynx, sir.
Yeah.
The
Now,
highest
isn't it interesting? Isn't it hypopharynx and larynx? Isn't it
Correct.
interesting that this trial showed a benefit in distant metastasis while more than 60 were in oral cavity? So I wonder if you have an enriched patient population skewed more towards hypopharynx and maybe even oropharynx or larynx, then the benefit might be even better.
Yes, sir, it would be. Sir, the problem with oropharynx is now, sir, though they included oropharynx, actually in India, very few would refer a T3, T4 oropharynx for surgeries. With the Oracle
That's
data
true.
coming, so I think the oropharynx is not something which we should be even. Oropharynx at present, chemoradiation will still stand the treatment of
The
choice.
standard.
Yes,
True.
standard. So the discussion will be for larynx, hypopharynx, and even
Oral
for
cavity.
oral cavity. Now, if you look at with respect to larynx and hypopharynx, when we are going for an organ preservation approach, at present we don't have data of neoadjuvant immunochemotherapy. At present, we have data for CTRT, we have data for hypopharynx for neoadjuvant chemotherapy. So again, for organ preservation also, this won't be useful. This will be useful where you are going to knock off the larynx and hypopharynx. And those patients do have high risk of metastasis.
Vijay, can I just jump in
Yes,
here?
sir.
Can I
Yes,
ask?
sir.
Yes.
Why do you say it won't work with chemo-RT? There are some studies with other immunotherapy agents. The Chinese have published using this approach, I think last year's ASCO, giving neoadjuvant immuno and then giving chemo-RT and showing it useful. Conceptually, tell me why it should not work in the organ preservation. And Rakesh, to answer your question, most of the locally advanced larynx and hypopharynx and it's supraglottic larynx, not glottic larynx that has distal metastasis, will all be treated organ preservation unless cartilage is destroyed or the larynx is incompetent. So the majority of them will go for organ preservation approach, and that's the reason why it's skewed towards oral. the number of patients that they would see in the West who would demand surgery in that setting is very few. They would all
True.
go organ preservation, and that's compelling data. No one can change that. That's the RTOG 911. It's gone through VA trial, EORTC, then this. So it's very robust data.
Also,
Yeah, I
there is
agree.
one potential question is that what will be done for cisplatin ineligible patient, because here the CTRT was with cisplatin. So there are a couple of things, and also in HPV negative population there was one data, although in advanced setting was with arenavirus therapy. So many things are coming into vogue, I
I'm
believe.
sorry.
And
I have
yeah,
one more provocative question. Provocative.
yes.
Now we are recognizing the importance of lymph nodes preserving T cells. Is there any subset where we don't need to dissect the lymph nodes or not to irradiate lymph nodes in this setting?
I can jump in with you, but I can jump in because
Yes, please.
Yes, sir. Please, your comment will be very valuable.
yeah, the sentinel biopsy champions led by Claire Schilling are now making a very compelling.
Sir, we are not able to hear you properly.
Hang on. Why can't you? Can you hear me now?
Yes,
Yeah.
yes.
Okay. So, Rakesh, your point is theoretically and conceptually very provocative. People are researching on that point. People say don't do the elective neck dissection, just do the sentinel node biopsy, and then it would give you some immune priming response in ultimate outcomes. But the research is still going on there, and the sentinel node biopsy champions are using exactly the argument that you just put forward to champion the cause of sentinel node. Otherwise, it's not gaining much steam. It is proven to be beneficial, but it's a very cumbersome procedure and many people can't do that. So they're championing this cause now as another added advantage of SNB.
Thank you very much.
Right. So I think, there could be some other approaches also. There was some data which is with immunotherapy along with EGFR inhibitors. There is something with antibody drug conjugates also, which are coming into, scene. So future is bright. That would be my concluding remark. And I'll hand over to Sujit for the last bit. Very interesting discussions. Thank you for a very active participation.
Yes, very interesting discussion. Thank you, Dikru sir, for joining in and giving your comments. Yeah. And thank you so much, Atul Sharma sir and Dr. Vijay sir for an excellent talk. Actually, this is very relevant for our country, because when there is data like this and it is said to be a level 1 evidence, there is a high chance that people will adopt it, but we should know the nitty-gritty of these approaches. And we had a very good participation with 350 people joining today for this webinar, and that shows the interest of on this topic. With this note, I think we can conclude this session, and inviting all of you again for the IOCCon meeting in January 22 to 25 in Chennai. We'll have more of this discussion. The topic itself is immuno-oncology in multidisciplinary care. More of adjuvant and neoadjuvant IO will be taken into discussion. We also have parallel scientific session from the basic scientists. Dr. Girdhari Lal would be taking care of that very interesting scientific discussions on basic immunology and research that is happening. With that, we'll conclude this webinar. Thank you very much.
Thank you very much. Thank you very much. Bye-bye.
Thank you very much. Yeah, and
Thank
a
you.
very
Yeah.
warm welcome for all of you to come on board for the
Yes.
next IOSICON national meeting. It will be an academic